The topic of discussion today will be on retina examination or funduscopy. Now, the overview of the presentation, I will mention briefly on the anatomy, particularly the clinical relevant structures, and we will look into our instruments and lenses, particularly the slit lamp and also the bilateral indirect or funduscopy. Briefly on the anatomy, I will not be able to go into too much detail in terms of the retinal anatomy, but clinically, just to recap that how do we divide the retina when it comes to description clinically? Depends on the pathology that we are describing. So when we have a vascular pathology, for example, we might want to divide the retina based on the four major branch of the retinal vessels, which is the supratemporal quadrant, supranasal quadrant, infratemporal as well as the infranasal, followed by the optic disc, and lastly the macula. But if let's say we have a mass or big lesion, we might want to divide or describe the lesion according to the region of the retina, which can be divided as superior, nasal, inferior, or temporal. Or we can also use the clock hour division to describe in more detail on the extent of the lesion, right? Or maybe we can actually use a combination of the location as well as the clock hour. Now, everyone can actually describe a funduscopy, but what is lacking most of the time is the detailed description of a lesion. All right. When you observe a lesion, you have to imagine from the beginning what you're going to tell your colleague, what kind of description that you're going to share with your seniors. So in order to do that, you have to scrutinize the detail of the lesion. So if you observe, I think most of us would agree with me that a lot of juniors, when I was young, I also did the same thing. We are more comfortable with the wide field lenses. The 90 diopter lenses, super field lenses. But the more senior you are, you tend to use more than one lens, right? And you will be seeing those seniors using a lot more of the magnified 78 diopter lens when it comes to, particularly when it comes to the macular detail. Probably as a start, when you see or you want to describe anything on the retina, make it a habit that you are going to describe 5 things about each of those structures. For example, if let's say you're going to describe the optic disc, try to look at the detail of the optic disc. Just don't stop at 0.3, pink, healthy rib. Describe the detail as what you describe for the glaucomatous disc. Look for the peripheral atrophy. Look for the presence of a normal sized disc, whether it's hypoplastic. Look at the margin. If there is a pulsation, make an attempt to document the presence of the pulsation, the venous pulsation, right? Now, look at the vessels. What else do you look at the vessel? When we look at the vessel, we try to look at the, of course, AV ratio, right? The tortuosity, the presence of AV nipping, the shielding, if there are shielding at the periphery especially. And when you look at the macula, apart from looking at the foveoliplex, also look at the vessels around the fovea, whether it's actually tortuous, because that could be a sign that there is some kind of early epiretinal membrane, which can be easily missed. Another finding that is also commonly missed is the cystoid changes at the macula. If you have a large cystoid changes, it could be quite obvious. But if let's say there's a single cyst, an early cystoid changes, it can be easily missed unless you look hard for it. When there is a pathology, what do we describe with a pathology? We describe the location, in which quadrant it is, in which layer it is involved. It is pre-retinal, subretinal, or intraretinal based on the shape and also certain characteristics of the lesion. Look at the relation to any important structures. That is also one thing that can be easily missed in any description of the retina. For example, especially when you look at a torsoplasmosis lesion, You want to describe it is adjacent to the major vessels, it is adjacent to the optic disc, it is adjacent to the fovea or the macula, how close it is to the fovea or the macula. So all those relationship to the any important structures in the eye is worth highlighted. Right? Don't forget about the size. Our reference is the optic disc. So whether it is half of the disc diameter or is it double, twice of the disc diameter size. Now, when it comes to activity, again, look at the associated features, particularly the what we call pathognomonic features, if there is any pathognomonic features, the ages of the lesion, whether it's elevated or excavated. So try to make a point to be more detailed in your observation, which will bring to a more detailed description of the findings. All right. So when you have that kind of detailed, kind of systematic kind of thoughts, it becomes something. It's like a reflect. So when you go for the exam, it will not be difficult for most of the students. All right. Now, let's see what else are commonly missed. Now, apart from the optic disc, apart from the major vessels, if let's say you're using the wide field lenses, right, you can also describe a lesion, whether the location or the size in relation to the vortex vein, the location of the ampulla of the vortex vein, all right, which is in pretty obvious in each quadrant. You can actually denote, let's say there's a lesion in the nasal side of the retina, extend from the equator up to the ora strata, for example. Or you have a lesion in the superior part of the retina, which is about 3 disc diameter of size, located about 2 disc diameter away from the optic disc, extending up to the equator. So when you describe any lesion in relation to the what we call important structures of the eye, people can actually imagine what you're looking at. So the description will be very, very detailed. Okay. Now, what else is important about this vortex vein? It tells you where is the equator. All right. Then don't forget your long slither nerve. This is very important, especially when you want to do the lasers, PRP or peripheral lasers. It is quite common. Let's say you're doing a pen-retinal photocoagulation. At the beginning, everything was, patient was very comfortable. When you reach a certain horizontal line, and the patient will start to complain of pain. So you probably has hit, one of these, very much close to the nerve. So those are the location or the structures that you try to identify when you look at the funduscopy. Now let's look at how else you can use your disc diameter to describe a size of a lesion or a distance in the funduscopy. So 1 disc diameter is equal to 1.5 millimeter. That's commonly known. But let's say you want to describe anything. You see a lesion which extends from the equator up to the ora strata. It is about 4 disc diameter size. Anything between the equator to macula is about 6 disc diameter size. And if let's say you have a peripheral lesion, at the aura of 1 clock hour, it is about 3 disc diameter size. And you have anything at the equator, it is actually larger because equator is the largest diameter of the eyeball, and it will be about that 1 clock hour at the equator is about 6 disc diameter size. So, in other words, if you have a retinal tear, for example, at the periphery, it actually could be a small tear compared to if you have a tear at the equator. All right. So you can use the disc diameter based on the distance to describe how big is the lesion. Remember, what you see inside has a direct relationship to external anatomy. For example, your pars plicata starts around 2.5 meters from the limbus and it extends to your pars plana, eventually your ora strata and your retina. So this measurement is very, very important because, as you know, that the retinal starts or the ora strata is coincide with the insertion of the right eye muscle. So in case you have a laceration, for example, Usually, we will measure the laceration from the limbus and see how far it goes behind the limbus. Anything beyond, let's say about 6 or 7 millimeter, our worry is the retina might be involved. Right. Now, this is just to show the example of how juicy or how big is the normal vortex vein. So this is what we found during that section of the retinal. This was during one of our buccal sessions. So from here, from the cornea up to the equator, the measurement is about 14 to 16 millimeter up to the equator. All right. And this is particularly important, especially again, not only during the trauma cases. Even if you want to do as simple as subretinal injection, be very careful when you are dissecting. Do a blunt dissection of the subretinal rather doing the cutting, open and close your scissors in the subretinal space. So you have to be careful and be aware that in between the muscles, there are the vortex vein, which is not so far behind. Now let's look at our instruments that we commonly use. Of course, the slit lamp. I think everyone is pretty much aware of all the mechanical part or the external part of the slit lamp. But if let's say you're sitting for your exams, for your RCO exam, or for your ICO, for your master's exam, postgraduate exam, try to look at the slit lamp at a very different way, you don't just see the slit lamp as a slit lamp as it is, not just look at the joystick, the eyepiece, the headrest. Look at the slit lamp in the way of the optical system of the slit lamp. Try to understand the optical system of the slit lamp, try to make all your basic optical knowledge more clinically applicable. I will not be able to go into detail of this, but just to highlight that in the eyepiece itself has its own, optical description, even the technique of examination, the lens that we're going to use, everything, you just have to know how to draw those optical system and try to understand how it works. Now, when you talk about retina examination or any slit lamp examination, the posterior segment examination starts from the anterior vitreous face. Or even before that, which is the red reflex. Whenever you start to shine the light, you try to make a slit beam, trying to examine the fundus. When you try to make a slit beam, automatically you can see the red reflex. So that is actually step number 1. That will actually able to tell you what is happening at the back of the eye, right? Whether the red reflex is reduced, whether you have this sunset glow, whether it is actually very good. Okay, now after your red reflex goes to your anterior vitreous face. Okay, so try not to bypass your red reflex. That is a very, very important step because it tells you, how good the media would be and how clear you'll be able to see the retina. When you see anterior vitreous face, you just have to focus slightly behind the lens or behind the intraocular lens and try to appreciate not only the presence of cells, the color of the cells, what are the sizes of the cells, what about the status of the vitreous? Is it cyanoretic? Presence of any tobacco dusting? And if you're lucky, you can actually see a collapsed posterior hyaloid face. All right, so those are also an important step which will assist you to diagnose whatever pathology you're going to deal with on the retina. So try to make a point to examine the peripheral retina first as a step, or the optic disc. So avoid the macular and leave the macular towards the end. If I know it's going to be a long examination because I need to put things in detail, I put a bit of the topical arcane in both eyes. So we start with peripheral retina, look up, right, up, left, and then ask the patient to look to your right ear, and then goes to your right shoulder, look down, look left shoulder, and finally to the left ear. So try to be systematic. And lastly, I will go for the optic disc. And lastly, we go for the macula. But remember, when you do the macular examination, reduce your light intensity. So that patient will not be, especially when they don't have much of pathology at the macula or the macula is functioning very well, it will be very bright for the patient. Now, when you do macular examination, what lens do you use? Of course, ideally, when you do a screening, you want to use a wide field lens. But when you do a macular examination, of course, the best lens is your 78 diopter lens. Or, people will advocate you to use a 60 diopter lens to examine the optic disc. So when you go zoom into any macular pathology, using a magnified lens will give you much more detailed description, right? So in any circumstances that you're not sure whether there's an elevation or not, what should we do is you should switch to a contact lenses, all right? In certain circumstances, what we do is we, with the contact lens on, we slit the beam and we tilt the light, at about 45 degrees. So, and start to move your light across the lesion. And you start to appreciate the elevation if there is any. Okay. Again, try to correlate any symptom and signs that you see in the macula. So if you see, for example, an epiretinal membrane, okay, which denotes a crowding of the photoreceptors, patient might complain of macropsia. But if you see, let's say there's a swollen retina, whereby the photoreceptors are actually spreading out, so you might expect the patient to describe as macropsia. Okay, try to sort of correlate as much as you can, not only correlating the vision and also the pathology, but also the vision and also the detailed description of what the patient sees. Sometimes I realize that we don't routinely ask, right? But then just try to make a point. Instead of asking about just stop at reduction of vision, try to ask about the quality of image that they're looking at, which is the size and the shape. Now, don't forget about, apart from looking at in detailed description about the macula, don't forget to do the Watts-Allen test. Now, Watts-Allen test, I think most of us will know about this. You slit the light. In some papers, they would describe, slit the beam to 100 micrometer of size, centered at the macula, and test the Watts-Allen in a vertical and also in horizontal orientation. But generally, what we always advocate is you have to make sure that the size of the beam has to be smaller than the size of the hole or the size of any macular lesion that you're looking at. Usually, we use this to describe about whether it is a true hole or is it actually a lamellar hole. Any kind of distortion at the center part of the beam, which is either crooked, thin up, or even absent, is considered as a positive Watts-Allen test. Depends on the size of the lesion. Now again, if you're unsure, then instead of using your condensing lens, the 78 diopter lens for Watts-Allen test, the best method, again, if you're not sure at any point, you are hesitant, is to use the contact lens to test the Watts-Allen. Now, let's talk about the commonly missed macular lesion. In the era of our OCT era nowadays, I find that we tend to underdiagnose cystoid macular edema, particularly if there's not much of changes around the macula in terms of heart exudates or dot blood hemorrhages. But to look for or describe the cystoid changes per se, if you don't look hard for it, and if you're using your wide field lenses, usually you will miss it. All right. For cystoid changes, you have to look for it. Use a high magnified lens or a macular lens, and appreciate the shape or the elevation at the macular region. So you don't really need an OCT to diagnose a cystoid macular changes. Sometimes we can also miss the presence of any active bleeding within an old scar, even a PED, macular hole, epiretinal membrane, especially at the early stages, whereby you don't see much of you don't really see that sheen of ERM, but the earlier part, probably what you see is just the very much crooked vessels, and also even the NVD and NVE, especially NVD in a young patient. One of the clues that tells you this patient is actually having an active NVD, one of the clues that this patient might have an active PDR is when you see that this is hyperemic. Right? Again, if you don't look for the NVD, you might miss it. Macular dragging is another one. This kind of situation, if let's say you get a very much very obvious lesion like this, I think most of us will not miss it. But I find that, especially in diabetic cases, remember that we always try to correlate what we find and also the vision of the patient. Let's say you have a case, patient has 660 vision, lens looks very quite clear, macula looks more or less very much quiet, or what we call a burnt out kind of changes. But yet the vision is poor. People tend to sort of blame on the ischemic maculopathy, but before you do that, I strongly advise everybody look at but now we have the OCT, so it also helps us to diagnose this macular dragging, which is, for me, is a bit underdiagnosed. All right, macular dragging means the location of fovea is being displaced, basically. If you have a patient with DRG, for example, in this particular case, he still have some active lesion peripherally, and what we see here is actually an incomplete kind of PVD with fibrosis around the optic disc, and you can also appreciate that the vessel is quite straight. So normally it should be quite curved around the fovea, but you can see obviously this one is very quite straight, and at this particular time, you can actually appreciate that as if the retina is being pulled toward the optic disc. And true enough, when you do the OCT, you can see actually the macula is a bit displaced towards the optic disc. So this is a macular dragging. So in any condition that you think there is a fibrosis component, first of all, you need to see the fibrosis, and the vision is poor, rather than jump straight on the macular ischemia, in which we usually don't for anything. Look hard for the macular dragging, which tells us the macula is already involved. Now, peripheral retina. The eye doesn't see what the mind doesn't know, right? So you have no choice but to look at a lot of pictures and see how it looks like. So that what I realize is a lot of us like to label a peripheral changes as lattice. Yeah, because lattice is very much common. But again, lattice is something that you have to watch very closely, and sometimes you have to treat. Whereas in some peripheral degeneration, let's say for Pavin stone or snail track, you don't really have to do anything. Pavin stone is probably quite obvious. I think most of us will be able to describe a Pavin stone, but it's also commonly mistaken with a hole, an atrophic hole. So you don't really have to laser Pavin stone, just leave it. Now this is snail track, all right? We have come across that, sometimes people mistaken it with a lattice degeneration, especially when you use this white field lens. You see everything is just white. You might thought it's actually a lattice degeneration, but it is actually a snail. White without pressure is easily seen with the white field lens. Now, when it comes to lattice, the common site of lattice, of course, at the periphery, and the orientation is usually circumferential, right? When you see a lattice very much posterior at the equator, or posterior to the equator, or what we call a radial kind of lattice, the orientation of lattice is actually radial, directing from the aura towards the posterior pole. Those are the abnormal lattice, and usually it is associated with any systemic pathology. Now, when you look at lattice, of course, there are pigmented lattice and non-pigmented lattice. Look hard for any holes within the lattice. And this is an example if you have lattice-related retinal tear, a very large retinal tear which is commonly occurs at the posterior edge of the lattice. All right, so you can see a very nice bridging vessels. Now, before we go into the bilateral indirect ophthalmoscopy, let's go into the lenses that we use. Various type of lenses, convex and concave. We are using the condensing lens for slit lamp. We use the condensing lens for our BIO, and we also use our contact lenses. Now, for the exam purposes, part 1, know that when we use a condensing lens, we mean the convex lenses. Various type of lenses, various sizes. The easiest to remember is the higher the dioptric power, the smaller the size of the lens, as you can see from 20, 28, 70, and 90. So the high dioptric power, the lenses become smaller. The image that you see is also smaller, and obviously the working distance between your hand, also the patient's eye, is also shorter. Now, these are commonly used lenses for the binocular indirect ophthalmoscope. 20 diopter is the most common lens that we use, and we have the 30 or 28 diopter lens, and another one is the 2.2 lens. Now, what are the differences between all these lenses? Now, when I first started with the BIO, of course, we used 20 diopter. But then when you progress, you start to use 28 or 30 diopter lens. And you start to feel a bit more comfortable with the lens because it gives you a bigger field of view. Right? Although the magnification of the image is much smaller, but for the purpose of screening, especially for, let's say, for any retinal tear, looking at the extent of the detachment, looking at the presence of retinopathy of prematurity. So 28 diopter lens allows you, it gives you a very nice wide field of view compared to your 20 diopter lens. However, the image is being sacrificed. That means with the 30 diopter lens, the image is much smaller compared to your 20 diopter lens. Now came in the 2.2 pan retinal lens. Now, if you ask me, I love this 2.2 because it gives you still a wide, good field of view. If you look at the number, it is more or less close to the 30 diopter lens compared to 20. But it also has a much more magnified image compared to the 30 diopter lens. So in other words, 2.2 is actually gives you the benefit of both the 20 diopter and also the 30 diopter lens. So it gives you a wide field of view without much of compromising on the image size. So in other words, let's say if you have an ROP case, usually what I used to do is I will scan with the 28 diopter lens if there's a presence of line or a possible ridge. I would probably, and I would change to the 2.2, right, to look for the volume, to look for the presence of abnormal vessels. So that is an example of how you can use the combination of those lenses. And the good thing about 28 or 30 diopter lens, you can use it for small pupil. So in other words, which lens we choose for a BIO depends on what you want to look for, all right? So just to highlight the beauty of your 2.2 again, with a wide field of view, with still a fairly nicely magnified image of the lesion. So this is the lenses that I always have with me, but the common one that I use is 28, also the 2.2 lenses, all right? Now, again, this is what I'm saying. If you use your condensing lens at the slit lamp, you might not feel the difference in terms of the walking distance because the difference between those lenses are quite close. But when you use the binocular indirect ophthalmoscope, if you have a 20 diopter lens, this is actually the distance between this is your working distance, which is quite far. If you have a small eye, this can be quite, if you have a small hand, this could be quite difficult. And as compared to the 30 diopter lens, you can see it's very much closer. Yeah? Not only that, the size of the lens is smaller, and it's also good if you're dealing with small eyes or deep-seated eye, and those kids who are not cooperative. 28 or 30 diopter lens is very, very useful. Okay, in other words, what kind of lenses you should have is the combination of both, the wide field lenses as well as the one that give you a bit of magnification. So in other words, if you're using a slit lamp, I would strongly advocate you to have this at least 90 or superfill with 78 or 60 diopter lens to look at more detail when it comes to macular lesion, a magnified image. And when you use the BIO, again, a combination of wide field lens with a more magnified lens, either 2.2 or 20 diopter lens. Now let's look at the contact lenses. All right, we usually use this either for diagnostic purposes when we are not sure or we want to look in more detail after we have screened the retina, or I think we commonly use it more for the therapeutic purposes, which is for lasers most of the time. Now, I know everybody is quite familiar with the 3 mirror. I find that these 3 mirror lenses are good for diagnostic purposes. Yes, it's good if you're not sure on whether there's actually a true tear or whether you want to look at the detail of your peripheral lesion. Yes, a 3 mirror is a good diagnostic tool. But when it comes to for therapeutic purposes, let's say for barricade laser, for peripheral retinal, pen retinal photocalculation, it is quite a struggle because your view is very much small and you have to keep on turning the lens, and it's very, very uncomfortable for the patient. Bear in mind, if you do those contact lenses, you really have to make sure that your patient is comfortable for a reason so that you can actually complete the laser in one session. Remember that ideally, PRP should be completed within 2 or 3 sessions. So if you are not able to complete the laser within those 2 or 3 sessions, you are going to drag the whole process of the disease to up to 3-4 months because you are only able to give us very certain limited number of shots on every session. So to me, 3 mirror is a nice diagnostic tool, but not as a therapeutic or not for therapeutic purposes. Now, for therapeutic purposes, I would strongly advocate to use a wide field lens, right? Such as the super quad. It's not the usual quadrispec lens, but it's a super quad lens, so it gives a very bigger field of view up to the aura, and even better if you can use the HR wide field lens. The HR wide field lens is actually what we call an upgraded version of the super quad, and it is smaller in size. So it's very interesting because I'm sure you have come across patients who are not cooperative, whereby the lenses does not fit in nicely with the patients. So what happens is you are only able to barricade the posterior part of the tear, but not the anterior part of the tear. So in those situations, I find that the HR wide field lens is very, very useful. Number one, it's very small. As you can see, it is actually giving a more the same field of view, but because it's very small, it's very light, it can actually sit nice in a very small eyeball, in a deep-seated eye. Everything would be very much easier for you to do. I would strongly advocate for centers to have the HR wide field lens. Now, again, how to choose your lens. Do this based on what you want to find. Let's say this is a bedside examination, well-dilated pupil, you can use the PIO or any kind of lenses with the PIO. In PITS cases, of course, it's nice to have a PIO. Even though it's a well-dilated pupil, you do not want to use the bright light or the large size of light. Now, when we do the binocular indirect ophthalmoscope, I'm sure everyone is quite familiar. When you have the ophthalmoscope, first thing first is to fix the ophthalmoscope very nicely on your head. Adjust the band at the back and tighten it at the top as well, so it's very stable. But do not forget as well to actually reposition the eyepiece of the indirect ophthalmoscope in relation to your own eye. Make sure it is at the same level, because sometimes if you do not adjust it, what happens is the eyepiece of the indirect ophthalmoscope will be much lower than your level of the eye. So what will happen is you have to bend your neck a lot more to be able to see through the indirect ophthalmoscope. So this is what I mean. When I was a junior, I do not know this. When I become more senior than earlier, I know that actually you can adjust the position of the eyepiece of the indirect ophthalmoscope, so it becomes at the level of your own eyes. Okay, now this is an example, one of the indirect ophthalmoscope. Of course, you can push it away or bring it towards your eye. But at the same time, there's another knob there that you can actually just know. Can you see that? You can actually adjust the position of the eyepiece in relation to your own eyes. Okay, so that really helps in avoiding too much strain on your neck while doing probably a long kind of laser treatment, maybe, you know, that is when you really need to have a very nice position of the indirect ophthalmoscope. Now, when you look at the choices of light, of course, you have a very bright light from the direct ophthalmoscope. But even though there's a well-dilated pupil, you don't have to choose the most biggest size of the light. What you can do is you just use a small aperture of the light so that you can actually reduce glare for the patient, and they will be more tolerable, and especially in kids. Even though the pupil is well dilated, try to avoid using the big size of the light source, and just use a very small size of the light so that you can complete the whole examination without much of a problem. All right. Now the same goes how to do a sclera indentation. It will be nice, it will be good if you are able to do the sclera indentation, not only to diagnose, but also to treat patients such as your ROP cases, your peripheral retinal tear, you can do cryo to those tears, you know. So it's good if you can actually learn how to do the sclera indentation. Now, at least 5 important steps. Darken the room and make sure the pupil is well dilated. When you do the indentation, you can either do it on the over the skin, all right? Or you can actually just put a bit of local anesthetic, then the topical eye drop, and just indent directly on the sclera. If you look at the sclera indenter, usually it has double-ended, right? So one end has a very small tip, a blunt tip, and the other end has a very much horizontal and wider, surface. So what happened is, usually if I give just topical anesthesia to the patient, I'll use a small tip end to do the indentation. Let's say you want to indent inferiorly. So you will glide in your indenter at 6 o'clock, for example, until you reach what we call soft stop kind of thing, which is the end of the fornix, right? So slowly what you do is, once you have slide in and reach a soft stop, what you do is you try to bring the tip of indenter into the eye. So you're actually pressing the eyeball and inwards, yeah? And by then, you will start to put your condensing lens so to see through and examine the retina. So your indenter should go first. Once you're in position, then only your lens will come in. Again, the best thing to do is, once you're in position, you will ask the patient to look into the direction of where you are indenting. Let's say you are indenting inferior. Once you're inside, you will tell the patient, can you look down? You can feel where I'm actually indenting. Can you look towards where I'm indenting? So at the same time, you will have the maximum field of view when you're doing your examination. Why BIO is important? Because it has multiple functions. Basically, you can examine the kids. You don't have to touch the kids. You can do a bedside examination. You can use it as a magnifier. It can go through any kind of density, mostly, which is hemorrhage, as well as even cortical cataract, dense nymphosclerosis occasionally. And it also helps you to treat the peripheral pathology. And just remember that it is contraindicated in any recent penetrating ocular injury or any recent intraocular surgery. Again, how to choose your lens depends on what you want to see. So you have to decide from the beginning what I want to look for and what lens will be the best lens to use so that you can actually cut short your examination process, right? And not to miss any important findings. Now, last but not least is always love your neck, love your spine, always learn how to use all your instruments correctly. And with that, thank you.